get started in just a few minutes. Thanks for being here. Hopefully you can see the screen. Um, Please do introduce yourself in the chat. We'd love to see who's here. Also, a note what brought you to the forum today. If this is your first forum or you've been here a couple times, I do see some familiar faces, which is great. Welcome back, but we'll get started in just a couple minutes. All right, wonderful. For those who just joined, we're going to get started in just a minute or so, but please introduce yourself in the chat. I see some wisdom participants, as well as physicians who have been supporting the study. Thanks everyone for being here and not only for participating, but also for being engaged in these discussions. It's a great opportunity for us to share information back with our wisdom community, but also to have a dialogue and to understand what matters most to our community members as well as to our partners and supporters. So we'll get started in just a minute. Thanks so much. All right, it is 3 after, so we will get started. Once again, welcome everyone to our monthly community forum for the Wisdom Study. This is our forum for November 25th. This will actually be the last forum of the year. We will be canceling December due to the holidays. These forums usually happen the last Monday of every month. And so with the holidays at the end of December, we decided just to cancel and we'll reconvene in January. But again, if you haven't introduced yourself, please do so in the chat. I'm Allison Fiscalini. I'm the director of the Athena Breast Health Network and the Wisdom Study. And my team at UCSF is the coordinating center for the Wisdom Study and helps to organize these events, as well as sort of overseeing the Wisdom Study operations and implementation. So welcome. Just a quick note on today's format. We do want to hear from you. Our intention is to have a dialogue and to hear what your questions are and be able to answer those questions. So please do raise your hand or speak up during the discussion. You can submit your questions in the chat. If you're not speaking, if you could please mute yourself. We are recording the meeting. These go on our YouTube channel just as a resource for others who aren't able to join. And we'll share out the link to that after this session. Additionally, there is a short post-meeting survey that will pop up at the end, and we'd love to hear your feedback, both on how today's session went, but also ideas for future sessions as well. So the mission, we've been doing these community forums since about 2020. The mission for these is really to move together toward equity and better outcomes in breast cancer for everyone, and to bring together both the researcher community, the clinician community, as well as our community at large to have these discussions and to learn about topics in women's health, in breast cancer, screening and prevention, and to be able to discuss some of the more relevant topics, recent topics that you may have heard in the news, but also questions that are top of mind for you as well. So we have a huge catalog of forums that we have recorded in the past and would encourage you to check out our YouTube channel if you haven't. If you'd like to go back and re-listen to any of these, we can put the link in the chat. But for this month, we will discuss AI, or artificial intelligence, and diagnosis and what it can and can't do. We are very lucky to have Sandy Borowsky, who is a pathologist at UC Davis and has been a longtime collaborator within the Athena Breast Health Network, is our principal investigator for UC Davis for the Wisdom study, and collaborates on several other breast cancer projects with our UC teams as well, around DCIS and other topics as well. So pleased to introduce you to Sandy Borowsky. And with that, I will pass off the discussion to him. This is actually a talk that was given at the more recent Rise Up conference, which we've mentioned on these community forums. Just to note that we do plan to do a recap of the Rise Up conference on a future forum, and to sort of highlight some of the key topics and discussions that were held. And that conference will be held again. It will be annual, so we'll let everyone know when it comes back up again. So yeah, Sandy, would you like me to move your slides, or do you want to share?
No, let me share from my screen. It'll be easier, I think.
Yep, no problem.
Thanks so much, everybody, for having me. And thank you in particular, those of you who are either participants in Wisdom, thank you very much, but even more so, those of you who have recommended other people to be participants in Wisdom. We can't do this without you, and we can't do it without the word of mouth to get information about the study out. I'm not really going to talk very much about Wisdom today. I'm going to talk a little bit about mammographic screening kind of at the wrap up, but mostly I'm going to recap this talk that I had to give in 15 minutes. You guys have a little more time. I do still tend to talk too fast, so if somebody puts in all caps "slow down" in the chat, I'll try and slow down. But hopefully you guys will come away with some impression of where at least I think things are going. And so share screen, let's share that one. So you should be seeing the title slide. And if things are going right, you should see my laser pointer. Are we doing okay?
Yep, you can see it.
Awesome. So again, I'm thinking about the future, and I'm thinking about AI, and for I think anybody in almost any career, this can be a little bit scary. So, in pathology, I think pathologists are particularly worried about the future and their lives and the details, and making sure everything's perfect, which makes us a little bit stressed out sometimes. But for us, I think that we can view the advent of AI in our practice as a sort of a crisis. But I like to point out that JFK is attributed with the observation that the Chinese characters for crisis are a combination of the Chinese character for danger along with the Chinese character for opportunity or chance. And so every time there is a crisis, it may be a danger, but it's also an opportunity. And so I think we need to think about how to take advantage of that opportunity. I hope you all agree. I put these QR codes throughout here. So if you do have your cell phone camera out, you can see little details that I won't have time to talk about. In particular, there's a nice Wikipedia page on this JFK thing. And this is a bit apocryphal, so it's not exactly 100% true, but the Wikipedia page does a nice job of explaining it. So when I think of the three big deals in pathology today, these are the three big ones for us. And today I'm mostly going to talk about the third one, but I think that the advent of next generation sequencing, transcriptomes, metagenomics, which is sequencing, the flora in your bowel, metabolomics, understanding all the details of all the metabolomes. Um, these are a bit of a crisis for pathologists. Oh, my automatic lights went out. Because they require a huge investment in expensive equipment. And the average pathologist in the average hospital is not going to be able to afford that. And so it takes important assays out of the pathologist's hands, and specimens get sent to another place, sometimes a big academic medical center like UCSF, sometimes a big industry or company that has invested in developing the technology. And so as a pathologist, that to me is a problem, maybe also an opportunity, but a problem because I feel like I need to keep command of the diagnostic information and data. More and more, we're seeing blood-based testing taking the place sometimes of tissue-based testing. So while I make biopsy diagnoses on a routine basis, as more and more we're able to do things from blood, it may take those biopsies out of my hands. And again, these are largely done by big industry groups with information that, as a pathologist, I need to keep on top of in order to help my clinician colleagues interpret what they really mean and how to apply that to patient care. But today I'm going to talk mostly about AI in pathology, digital image analysis, and us carbon life forms are cumbersome. We're slow. It's expensive to train new ones. But ideally, as you'll see today, I think the use of AI technology um, may help us be more efficient, be more reproducible and more accurate, and finally to be faster. There's lots of things in medicine that I think will benefit by us being faster, and I'll kind of wrap up with the end of a vision that I have for that. So you guys have all seen the revolution of facial recognition systems, and AI is able to, recognize a face to something like 99.97% accuracy. They don't mix people up. So much so that your iPhone now can be opened with your facial recognition. And we're not too worried about somebody breaking into your iPhone because they happen to look a little bit like you. So what about pathology? Can the computer recognize cancer on a biopsy? And can it take my job away if it can do that? And so here's an example of a product made by a company called Halo that's looking at a prostate biopsy, and it has circled using its training the areas of prostate cancer and left the areas of benign prostate adjacent next to it uncircled. Um, and so to some degree, yeah, if we think about just a prostate biopsy and is it cancer or is it not cancer, the AI can already do this. This is something that AI algorithms have been taught to do. And if we look at the details of this, this is from what's called a meta-analysis, where the authors looked at 48 different studies that had been published. And they looked at the sensitivity, that is, how often did AI find a cancer that really was there by whatever gold standard. I think our gold standard is the pathologist said it was there. And then similarly, what was the specificity, or how often did AI think there was a cancer that wasn't there according to the pathologist? And you can see that all these studies are getting pretty close to that perfect line, the perfect line I added in red here. And if you're like me, these scans are hard to look at. This is the paper. If you want to find the paper, it's publicly available and you can read it in detail. But I like to expand these things out. And so I've added a dotted line here at about the 80 or 83% level. And you can see that all these studies, some of them are better than others, but all of them have both sensitivity and specificity issues on the order of between, anywhere ranging from, 1 in 5, which is, not acceptable, I don't think, for clinical work, to sort of 1 or 2 out of 100. And when we get closer to less than 1 in 100, then I think we're at the level that we really can trust the AI to make this assessment, maybe even without supervision. But the moral of this story here, and when they did the averages, this is what they came out with. So the average of the sensitivity came out at 96%, and the average of the specificity came out at 93%. And I think these numbers are not good enough to use just the machine's determination. You don't want to be the 1 of 4 out of 100 where we missed the cancer, or the 1 out of 7 out of 100 where we called it cancer and it wasn't. But it still can be used as a tool by a pathologist to kind of double check us and speed us up. And so if, for example, I had a case that I called negative and I said there was no cancer there, and the AI said, we think there's cancer there, it's a good time for me to take a second look. Maybe I skipped a piece, or maybe I just was looking too quickly. And so it's an opportunity for us to have a little help in knowing when to look a little bit more carefully and when to sort of make doubly sure. The other thing I like to point out, though, is that cancer is not really a yes/no question. We like to think about it that way. You go in for a biopsy, and the question is there cancer there, or is there no cancer there? And that's not really what I spend most of my time doing. I do that, but I spend more time trying to figure out where on the spectrum of a really bad cancer to a cancer that's not so bad does an individual diagnosis belong. And so this is just an example from breast cancer where you can see that the overall survival from different types of breast cancer varies fairly dramatically. And everybody with breast cancer does pretty well, but certainly the survival is not 100%, and obviously we want it to be. But nonetheless, these luminal A's, which are slow-growing hormone receptor positive tumors, sort of have the best outcomes. And so it's important to know, are you a luminal A, or are you a HER2 type, or are you a luminal B with HER2, or a triple negative? And so we spend a lot of time figuring out where on the big picture spectrum of breast cancer does an individual patient lie. And we were able to, a couple of years ago, use some molecular tools to really advance this by finding what we now call the ultra low risk category. These women up here at the top have almost a perfect 100% survival after a diagnosis of breast cancer based on this subdivision of ultra low risk in our Agendia assay. And so sometimes the answer cancer, yes, is really, well, that's not really cancer because there's no impact on mortality. So this is something we call cancer, but maybe we shouldn't call cancer. And so we spent a lot of time trying to figure that out too. And there's a lot of question about whether AI can help us do that more accurately, more reproducibly, and more cost effectively. So this is what we call precision medicine. When people say precision medicine, which is to measure characteristics that have distinct implications, both for the outcome and also to choose the optimal treatment for an individual patient. That's what I in pathology call diagnosis. So precision medicine and diagnosis to me are the same thing. And we as pathologists need to integrate all these diverse resources that we have, these complicated transcriptomic, genomic assays, along with what we see under the microscope to try and put together the complete picture of which patients are going to benefit from which therapies and what we can expect in terms of outcomes for each of them.
Hey, Sandy, real quick, there was a question in the chat.
Sure.
Can we know, or how do you know who falls into that ultra low risk category? Or
Yeah.
what's the definition of ultra low risk?
So that is, if I go back to that slide, that's in this paper, but it's also part of the guidelines. It's now in what are called the NCCN guidelines that clinicians all over the world use to choose therapy. And the way that the assay is done is it does get sent to a company called Agendia, and they can give you what's called a recurrence score, and that recurrence score has now this ultra low cutoff. So it's a complicated assay, but it's a really important one that's starting to become more widely known as a way to figure out who really doesn't need very much therapy at all. Maybe they need some anti-hormonal therapy, but they certainly don't need chemotherapy. And in the future, maybe these can be regarded as truly indolent lesions that we shouldn't really even put the name cancer on. So that's what we're working towards, is trying to name things better so we don't scare people. So where are we today? So we're already doing better than even that ultra low category. So, 50 years ago, we could recognize cancers under the microscope, and we knew that some of these cancers had malignant potential. That is, they could metastasize and they could grow in ectopic sites in the bone and the liver, and that this was the pathway towards these being lethal disease. But maybe 30 years ago, we started to look at things like, do they express the estrogen receptor? Maybe 25 years ago, we started to ask, do they express this HER2 molecule? So when we first discovered HER2, these were cancers that behaved more badly. But then we developed drugs specific for HER2. And so now we have a specific way of treating patients who have HER2 positive disease. That's grown into this new sort of second generation where I talked about, luminal A being slow proliferative rate, ER positive, luminal B being high proliferative rate, ER positive, and then the HER2s, and then triple negative means you don't express ER, PR, or HER2. And so we don't necessarily have specific therapies, but we still have therapies that are good for triple negative. And more we're learning we can further subdivide these. And so in this third generation, that the UCSF group pioneered recognition of an immune responsive subtype. So this immune positive subtype, we knew we could give new immunotherapies and have a good chance of success with those. So we're moving forward with better and better precision medicine, essentially being able to stratify patients into optimal therapies and know more about their outcomes. And a lot of this comes out of the I-SPY clinical trials, where we're able to really pioneer new ways of identifying patients that are going to respond to new drugs that are just coming onto the market. And we try to do that quickly so we can advance those new drugs into widespread clinical use as quickly as possible. So as a pathologist, it's a bit of a crisis because I have to keep learning. So here's my to-do list down here. I have to keep learning how to incorporate these molecular tools with the morphology I've already learned in order to provide a complete diagnosis. To do this, I need to understand how the testing methods work, and I especially need to know where the limitations or pitfalls. Where is the answer not quite right, and how do I determine that? So I think we're going to see these molecular methods really take hold in pathology. But to do so, I think we need to be willing to embrace the technology and not have it all be sent out to a company. We need to understand, even when it gets sent out to a company, what the report means when it comes back, and be involved, of course, in the development and validation of the next generation of tests. So I have a lot to do. You can see I've got a lot of hands here trying to keep busy. This kind of biomarker discovery is, again, a big part of what we try and do in the I-SPY clinical trials. Again, trying to figure out new therapies that fit into the categories that we don't have good therapies for, and at the same time, continuing to refine the therapies for the patients that we do have an idea of what those tumors are going to respond to. So what about coming back to this, AI, facial recognition, phenotype recognition? And here, I pointed out at the beginning that AI can recognize cancer versus not cancer, but maybe we can also teach it to help us do this complicated integration of all of the data that we have, both from the morphology of the image of the biopsy, but also from the transcriptomics data, some of what we call immunohistochemistry data, and put it all together and help us do that faster than kind of studying each case for a day and a half, put that together in reproducible and quantitative ways. And so again, I've got an ongoing to-do list of trying to, first of all, make sure that we get our slides. Right now, I look at a lot of glass slides under the microscope, that make sure that we get these digitized, turn those into images that the computer can see. The image can't see through a microscope without us helping it. We want then the tools to kind of run in the background before they get to my desktop, before I have to do the reporting, before I have to advise the clinicians. And so if those things are running before I even see the case, and then they can give me numbers and quantitation that help me, that's going to be a pathway to better diagnosis and more efficient diagnosis. And finally, can I continue to make this better? I think that at the end of the day, even though pathologists worry that the AI is going to take their place, I think the answer really is that pathologists need to be the primary users of this AI technology. So a couple of tidbits. Did you know? So these tools require digital pathology images. I've been working on this for a long time. So my lab back in 1999 was the first to own one of the now very common slide scanners to digitize slides. We were the first school of medicine to introduce whole slide images into the medical school curriculum. And then I was part of this study, which again, you can get from the QR code down here, where we proved to the FDA that pathologists could make a diagnosis from a computer screen the same way that they make a diagnosis at a microscope. And so this is now becoming a very standard way for pathologists to make diagnoses. I think the plan, though, needs to be that we need to continue to work with them. So rather than try and create obstacles for the adoption of AI technologies in pathology, I think we need to work with the companies and the computer programmers developing these things and tell them what we need. We need the AI to be able to find cells, classify cells, let us look at that and give us the data back, and insist sort of on the tools that we need. So one of the tools that I always tell them that I need is I need help counting mitoses. So I have to count mitoses on every breast cancer. This is a time consuming, sometimes difficult, sometimes gives me a headache because I have to look at high power at lots of areas of the slide. And if the AI can count mitoses for me and then show me where they are, I can just verify that it did a good job counting. That would be a huge time saver and probably a huge benefit in terms of pathologists all over the world being able to give the same kind of information. Now, is that a problem? Well, of course it's a problem. So the proliferative rate, first of all, in breast cancer is one of the primary ways that we distinguish who's in that good category and who's in a not so good category that may benefit from more chemotherapy. And if you look at just all pathologists as they go across, oops, I thought I had a zoom up of this. But if you look at all pathologists and look at what we call inter-observer variability, this mitotic rate score is really terrible. These are kappa scores at the bottom. This tells you what a kappa score means. If your kappa score is between 0.8 and 1, that's good. If it's below 0.2, that's almost complete disagreement. And so there's almost complete disagreement among pathologists counting mitoses on the same case. And we need to do better. That needs to be something that pathologists all give the same mitotic score, and we all give the same proliferative rate score, and then that data can be much more useful. In the case of prostate cancer, in addition to knowing is there prostate cancer there, yes or no, we do something called Gleason grading. And we've now trained AI to help us do Gleason grading. And the nice thing about that, again, is that if we train pathologists to do Gleason grading, they're always going to have slightly subjectively different answers. Now, we do a good job, I think, of training pathologists to give very similar answers, but it would be much more advantageous if we had a consistent and robust way of doing that the same every time. And so I'm very intrigued by AI tools to quantitate, in this example, 78% grade 3, 22% grade 4. If we sent this off to 100 pathologists, we'd probably get mostly pathologists saying there's both grade 3 and grade 4, but they might change the percentages. In fact, they would change the percentages probably substantially. So getting that to be much more quantifiable and reproducible is part of the idea. The other thing that I think is interesting to think about, and in full disclosure, this is a startup company called Histolix that I'm involved in. So I do have some founder shares in this company because I think it's so important. But here, instead of creating a glass slide, which is our current method, and then scanning the slide, we've invented a way that we can directly digitally capture the image straight off of the tissue without the time-consuming process of making the slide, going straight to the computer screen. This is exactly what radiology did about 30 years ago when they stopped using silver-impregnated sheets of film and they went to digital capture devices so that they could have instant reproduction of the radiology images. And so you might ask, well, does this work as well? And here's just a quick example. So we proved in this paper that it does work pretty much just as well. It looks a little bit different. This is the new technology on the top. This is the old-fashioned technology of making a slide on the bottom. And this is benign breast tissue, it turns out. You can see the little fat cells look a little refractile here, whereas in the section below, they're nice and clear. But I can easily interpret these as being benign lobules without any problem. And if I had a cancer, I could determine that. We even took these images from here and put them into one of those AI tools. And the AI tool, this is prostate cancer, didn't do quite as well, but it did detect that this was prostate cancer. So we're optimistic that if we train the AI to recognize prostate cancer that comes from our method, that we'll be able to put the AI sort of in between and speed the pathologist up in interpretation of these directly digital images. Another problem in breast cancer is the problem of having to have a lumpectomy and then a positive margin and then a re-excision. And here's an area where we also think that we can use both the direct digital imaging and the AI to speed us up. I won't go through all this detail, but this is to just show you sort of the rate of re-excision after lumpectomy. It varies by surgeon. Has to come back later for another surgical procedure to re-excise that area that was positive. And, this is how it's done. We measure on the permanent pathology exactly how far away from the margin the tumor comes. And there's been a lot of debate about whether we should do this with a technique called frozen sections. As Stu Schnitt, one of the leaders in breast pathology at Harvard, says, that it's hard to know exactly where to set the line, where to set the threshold. And so some of that, the answer is we don't know how to use frozen sections. The other problems with frozen sections is that frozen sections kind of destroy tissue. You lose it when you create the frozen sections, and freezing artifact can make it difficult and so forth. And so we think that using our direct-to-digital method will allow us to evaluate margins with no tissue destruction so that we still get it right on the permanent sections afterwards with um, no problems, but we get it right even during the time of surgery so that we can advise the surgeon that one of their areas is close. And so this is sort of the concept. Um, it's possible that the pathologist can here again be assisted in evaluating all these areas of margins using an AI type of method that gives a heat map to where the area is the most suspicious, and the pathologist can check that area and then communicate to the surgeon that it would be a good idea to take a little more tissue from the anterior or the lateral or whichever aspect is suspicious. This is a trick because now I need to teach the AI not just to recognize cancer, but to recognize these little bits that may or may not be cancer up near, we inked with blue so we could mark the surgical margin. And so we've developed a pathway to doing this where the AI first looks at that patient's cancer specifically, so it knows what that patient's cancer looks like. And then it looks at all these little areas along the edge and determines whether they are or are not cancer, and then you can do the measurement. And so that's sort of our plan. It's a work in progress. This is sort of how I would think about it if I were using my brain. And so we're trying to get AI to use its brain in the same way. Lastly, we all need to better understand the immune system. You guys have all heard that new immunotherapies are coming out all the time, that they're very promising. You probably remember that Jimmy Carter had melanoma metastatic to his brain, and he was treated with a brand new immunotherapy, and he was cured of his melanoma. And he's now lived to his 100th birthday, which is just remarkable for somebody with melanoma metastatic to their brain. So here in this diagram, which is from a few years ago, 2017, every one of these red words here is a drug that's an immunotherapy drug that's in the pipeline or in clinical use today. So I think we need to learn to be immunologists, and the best way to do that is to use computer assistance to help us understand what are the cells in the tumor immune microenvironment, and how do we use that assessment to determine who needs what kind of immunotherapy. Again, we need to keep learning and teaching immunology, but bringing these technologies in-house to be able to quantify the immune system. So that gets complicated. So when we look at the immune system, this is just a handful of markers that we use, and this is 2 panels of 7 markers at a time to try and tell us where the T cells are, where the T regulatory cells are, where the B cells are, whether those T cells are activated, and so on. This also tells us where the macrophages and the PD-L1 expressing and PD-1 expressing. This is one of our first drugs. That's the drug that was used for Jimmy Carter, is an anti-PD-1 drug that blocks the interaction between PD-L1 and PD-1. So these are all very important things to learn, but it's so much data coming at us that we need tools to be able to evaluate it. We use some of these tools in a DCIS study that we wanted to ask the question, why do some women with DCIS have invasive progression and other women do not? And what's the difference in the DCIS? And what we found after all this detailed analysis, again, with a lot of computer assistance, is that the important thing was whether there were T cells close to the tumor cells. And if T cells were close to the tumor cells at a high rate, that meant that they were preventing invasive progression. Somehow, we don't exactly know how, but it was a really good clue for us. And so in our summary, we said that, that this can be stratified, DCIS, based on the tumor immune microenvironment. So I think this is, again, now a preprint, not published as peer review yet, but you're welcome to check that out. as we start thinking about what else can the AI do for us, it can measure so many things simultaneously that it really kind of boggles the mind. But we try and keep a handle on it so we know what it's trying to do. And so here's another good example. And this came out of ideas that were generated in part at UCSF in the idea of mapping the tumor microenvironment as far as mapping the extracellular matrix components and whether they tell us something. And so here's just the example of looking at the extracellular matrix environment, the stroma around the tumor, and trying to see, does that help us predict outcomes? And it does. So seeing more uniformly directional extracellular matrix as opposed to haphazard matrix gives us very good discrimination of higher and lower risk all by itself. And so you can see these little diagrams here. We can overlay the different colors and where the epithelium is and what the arrows would be and how big those vectors are, and then summarize that into a single number. And so if we do this comparison of these two areas, first we map the squirreliness or the straightness of the collagen, then we map where the epithelium or the cancer cells are. Then we map again the direction, all the little arrows and what direction they're going. We divide that up so that we have little summary arrows or vectors, and then those can give us the sort of low disorder, high disorder, and stratify these two different cancers into different subtypes based on just that directionality of the extracellular matrix. I think this is super interesting to think about. Finally, we want this to be simple. So if we discover something that's very complex, can the AI help us reduce the dimensionality, reduce the complexity? And we think that in many cases it can. So if we find something that required my 14 different analytes and my 18 different types of immune cells and whether or not they're activated or not, can we reduce that to just a couple of markers and have AI do the rest of the prediction by putting that together in a logical way based on its training? This is my friend at Emory, Anant Matabuchi, and he is a computer scientist through and through, but he works in the pathology department there. And so he's been tasked with building a lot of these tools. And I enjoy working with him because he takes a refreshing approach as a non-pathologist by saying, hey, the AI is not magic. We need to be thoughtful. And we need to consult with our biologist friends about what we're trying to do here. It should be something that we can understand at the end of the day, not something that is just a black box that just gives us an answer, yes or no. And he also looks at the future where if we can do that dimensionality reduction, instead of a very expensive, complicated test, we should be able to do a low-cost, rapid test. And that'll allow us to have a global impact in low and middle income countries where we can apply these rapid, efficient, reproducible methods to help patients in all parts of the world. So I'm going to end with this little thought for you guys. And I think that I've been thinking a lot about this. I think we can do this. So wouldn't it be great if we could just, as a simple starting point, speed up what happens in diagnosis? So I just sort of penciled out what happens today. So today, a woman who comes in for a screening mammogram might get a call back about a week later. And then they'll get a scheduled, maybe 1 to 3 weeks later, diagnostic mammogram with a biopsy if needed. About a week after that, the path report comes back and it has the ER/PR and HER2 results. And then at least at UC Davis, it takes a long time to make that appointment to get in to see med-onc or surg-onc. So the referral appointment takes here, I'm being actually optimistic, 2 to 4 weeks, sometimes longer. But I think tomorrow we could reduce this 5 to 10 weeks down to a single day. So if the screening mammogram is automatically read by AI, it could be flagged to the attention of the radiologist in real time. The radiologist may be busy with something else, but they come to their computer screen and there's a big flag. And within 10 minutes, they'd be able to say, yep, that looks suspicious. We should call that patient back. Well, it's only 10 minutes. That patient is maybe not even dressed yet from their screening mammogram, or they've just gone out to the waiting room. And now the diagnostic mammogram and biopsy can be done on the same day. So the biopsy itself now could be digitally imaged directly and read by AI. And AI can even do things like predict whether the biopsy will turn out to be ER positive or HER2 positive. And that might take a little bit longer because, again, the pathologist needs to confirm that. So by the time the pathologist confirms that, sort of the same day or the next day, you could change the way we do scheduling and have that referral appointment either on the same day or the next day as well. And so in one day, you could come in for a screening mammogram and have a treatment plan, as opposed to 5 to 10 weeks. So I think that'd be pretty terrific. I'm eager to hear what you guys think about that. That may be a little bit shocking, but at the same time, it takes all that anxiety of waiting and wondering out of the equation. It gets right onto the, very precision medicine oriented, what we need to do to optimize care for that patient in real
Sandy, one of
time.
the things that I think you talked about earlier that I don't see in that step is the sending out the test or sending out for molecular testing. And so
Yeah.
that I think is, and one question I had when you were presenting on that with the Oncotype or MammaPrint, is that standard of care now across the board, or is that something that if someone were to get diagnosed, they should ask for, or how does that work?
Yeah. So at the time of core needle biopsy, it's not standard of care to get an Oncotype or a MammaPrint yet. Um, we've made it standard of care for I-SPY, so you don't enter I-SPY without getting a MammaPrint assay done. And I think that's for good reason. Um, I think we're getting very close to a point where that becomes standard of care. Um, but it is still an expensive test. And we know a lot even without the test. So on the basis of um, clinical staging. So if we know that there's lymph nodes positive, and sometimes the lymph nodes are also sampled by core needle biopsy, if we know that the proliferative rate is high, the grade is high, if we know that there's no expression of ER or PR, these things kind of put us in a different category. And I think when it becomes more important is when it's a lower risk hormone receptor positive lesion that doesn't look very large on the mammogram. There's an opportunity then to get an ultra low signature. At the same time, more and more we need to have that transcriptome assay to put us in the response predictive subtype category because we want to use what's called neoadjuvant, that is therapy that is added, but before we do the excision. So standard chemotherapy is after we do a lumpectomy or mastectomy. That's called adjuvant. Neoadjuvant is when we do the therapy before we do the lumpectomy or mastectomy. Again, this was pioneered by the I-SPY study. And it turns out that when you have a complete response in the breast, that is, by the time we do a lumpectomy, the pathologist, can't find any more cancer left. That's a very good predictor that we've treated the cancer completely, that patient is cured. And so we like the use of neoadjuvant therapy in that context. So I think you're going to see that changing. Where does that fit here? There's a lot of hope that the AI read can predict that MammaPrint assay with high fidelity. That is yet to be proven. That would be great because that's cheap, that's fast. Right now, the MammaPrint assay is relatively expensive. It's covered by most insurance plans, but as you know, not everybody has full insurance coverage. So it'd be nice to see a time where we can do that in real time, and I think we probably will get there. One of the big concept that I care a lot about, which is The genotype, that is what we find in the transcriptome through these complicated methods, the genotype it's directly related to the phenotype, the shape of the tumor. So there should be shape clues in the tumor that tell us exactly what the genomics are. But we need to discover those still. Anyway, there's a lot of fun things to think about there, a lot of good research to be done. In the short term, we are getting faster and faster with our transcriptomics assays. So if I know on day one of the screening mammogram that it looks like cancer, I could send that for the MammaPrint assay. And today, with no advances, I can get the answer back in a calendar week. Tomorrow, maybe I could get that to be run overnight and I get the answer back the next day. And that's sort of my hope, is that we continue to speed this up and increase our ability to do really refined precision medicine, but to do it quickly and efficiently. So there's already companies that are making software to help radiologists interpret mammograms. There's already companies publishing data that shows that they can predict the HER2 status of a breast cancer from the routine H&E stain without doing additional assays. So it takes a big team just when you think you've got it figured out. Everything, Mother Nature, tends to be more complex than you realize. And if we're not communicating well, we're all going to be wrong. But if we communicate, we're going to figure out that it's not a wall or a spear or a snake, it's an elephant, right? Not that these things are easy. It takes a lot of people. These are just a short list of some of my collaborators. And I'm happy to try to do my best to answer any of your questions.
Thank you, Sandy. Yes, if you have questions, please feel free to ask. There was one earlier on that didn't get answered, which is for the ultra low risk, what is the cutoff?
Yeah, so it's kind of just an arbitrary score. And if you look at the paper, we established that cutoff with one data set, and then we validated it on another data set in the paper. So it's not really fair to say, here's the cutoff, and look, it works perfectly in the data set that we established it on. We have to try it on a new data set. The MammaPrint scores, I think the cutoff became like I don't know, remind me, Allison, like a 19 or something like that for ultra low.
I
It's
would have to look
it's
it up.
it's
Yeah.
just an arbitrary number, though. It doesn't really mean anything other than how we put the algorithm together.
Mhm.
So can I ask a question, Lisa here?
Sure.
Really, really learned a lot. Thank you so much for your time and presentation. Your company, Histolix, is it in the process of working or still so do you actually use this device to, okay.
We do for research, the investors have decided that going to the FDA for approval is going to be long and expensive. And so they're actually kind of trying to push it in the veterinary pathology space right now. And so they've been talking to a lot of the big veterinary pathology companies about implementing it. In the meanwhile, there's a big research funding program called ARPA-H, so Advanced Research Projects for Health. The H is for health. And they've funded us to do this lumpectomy margin assessment. And so in the next 2 to 3 or 4 years, we're going to be working very hard on that and trying to bring that into the clinic.
That's great. That's a $20 million question. A
Yeah.
lot of different devices, gamma probes and stuff,
Oh,
and
yeah.
none of them worked. Yeah.
Yeah. No, I have very strong opinions about that from my pathology background. I think a lot of people forget about the degree of sensitivity and specificity that I showed on that one slide, where you're looking at just those squirrely little cells and trying to say, are those cancer or not? And so any assay that you've got that doesn't look cross-sectionally for how close the cells are, and then determine whether those cells are likely to be cancer. So if you're just looking at the surface, it's very hard to imagine they're ever going to get the sensitivity and specificity to the point where that's going to be a useful tool. But I think if we do have the opportunity to cross-section it, we'll be able to measure exactly what the distance is. I have a lot of hope for it.
Thank you.
Sure. Everybody ready for Thanksgiving? Hey, again, thank you, all of you, for your participation and wisdom. I can't tell you how important that is to me. I think we're really, we're hopefully in the next, what, Allison, about 9 months, gonna complete the wisdom, what we call 1.0, the first round of wisdom. And we've already started to move into what we're calling wisdom 2.0. The 1.0 data, I think, is going to change the way we practice. And I think in very positive ways. And then wisdom 2.0, we're really looking at a much bigger question of how do we determine effective ways to prevent breast cancer? And so that's what I really care a lot about.
Yeah, yeah. Very exciting stuff. Oh, it looks like there might be one more question. Maria? Maybe?
Yes.
Amber?
We need to do more research on what this impact of breastfeeding, exclusive breastfeeding, is on the prevention of breast cancer. There isn't enough done on it. And the marketing of commercial infant formula has seriously impacted our breastfeeding rates around the world. So that also affects how effective the studies are as well.
I think you're totally right. And actually, when we do get a chance to do a recap of the Rise Up meeting, there was a lot of discussion at Rise Up about about hormones of all kinds and the concept of pregnancy, lactation, involution, after lactation, the concepts related to you know, for example, oral contraceptive pills an opportunity to try and introduce cancer preventing agents along with those OCPs? And, that's a whole new concept. There was, a time sort of in the 90s when the OCPs were being engineered to have fewer side effects, which was great. But now we think they could also have a really beneficial side effect of reducing cancer risk. So I think all that, including, as you say, breastfeeding, longer term lactation, all comes into that big picture of what are the impacts of all these hormonal things on cancer risk in the breast. So we're very interested in that research. I take the attitude also of it's not just whether or not you get breast cancer, it's what kind of breast cancer you got. If you got one of those ultra lows, maybe not so bad. On the other hand, if you get something that is in our luminal B category and immune profile negative, we don't have good therapies for that right now. And so I heard a lot about figuring out what type of cancer are different women at risk for.
Right. Where do the SNPs fall into that?
Yeah, we're studying that actively. So the SNPs, for those of you who don't know, are what we use to generate what we call a polygenic risk score. And right now, our data is cancer yes, cancer no. But we're already funded by the NCI to study the question of what type of cancer do those polygenic risk scores mean, and are there different SNPs that give you risk scores for different types of cancer? So that's in the works. Great question.
Thank you.
Yeah, wonderful questions. Thanks, everyone. Well, to echo what Sandy said, thanks everyone so much for being here today and for your ongoing participation. We have had a huge enrollment in the last couple of months, last probably 6 months. And one of the top reasons people note that they heard about the study is from their friends and family and colleagues and community members. So please continue to share the wisdom study. I know as people head into the holidays and you're having conversations with friends and family, suggesting to people to join the study is always wonderful. If you're with family members, having a conversation around family history and cancer history in your family is also Not always the easiest topic to bring up, but knowing how important it is to share family history as you're gathering is a good opportunity to not only learn your own risk or to help others around you learn their risk as well. So we will be canceling December because it falls right before the New Year's holiday, but we'll be reconvening in January. We actually have in March, our topic is around breast cancer before and after pregnancy. So that's a topic that those questions that were just asked will be great for. So stay tuned for the March community forum as well. So we'll send around the updated topics for 2025, and just want to express my gratitude for Sandy being on today, for everyone joining, and for having such a great discussion and another year of wonderful community forums. So thank you, Sandy. Thanks to everyone for being here. Happy holidays, and we'll see you in January.
You're all allowed to go eat too much pie.